So good morning. It's Senate Health and Welfare. This is February 29th, a little extra time today, or 44 extra minutes, I guess, today, in the 24-hour period. How's that? It is an extra day. So this morning, we're going to hear testimony on 151 and beginning with, in particular, testimony on AHEAD. So I will welcome Pat Jones. Please, thanks for being here.
Morning, everyone. Morning. For the record, my name is Pat Jones. I'm interim director of healthcare reform for the Vermont Agency of Human Services. Thank you for having me. What I wanted to do was just start with talking about the goals of healthcare reform. When we think about healthcare reform, it's really how we seek to use public policy to address challenges in our healthcare system. And you know better than most because of the work we do that we're facing significant challenges, not only here in Vermont, but across the country as well. And so as we work to address those challenges, I thought it would be good to just talk about some of our shared goals. I think those are areas that we can all agree on. So that includes ensuring affordability, increasing and improving access to care and insurance coverage, optimizing the quality and experience of care for people using healthcare services, and also improving the health of the entire population, improving equity and reducing disparities in health and also in healthcare, identifying and addressing social determinants of health, ensuring adequate workforce across all of our care settings. And that's been a real challenge in recent years. Reducing complexity, and that includes where there's lack of alignment across payers, and that could be for things like payment models or quality measures or other aspects of healthcare. And then ultimately creating a sustainable healthcare system. And in Vermont, that really means a sustainable rural health system. We're seeing a lot of pressure across the country and here on rural healthcare. So the AHEAD model, or really any individual healthcare reform initiative, isn't going to solve all of those problems. And neither is one organization or entity. We've really got to take a multifaceted approach to addressing these challenges and trying to achieve our goals and really work together on that. And we've shown that we can do that in a number of areas. I mean, this body over the last couple of years has really done a lot of work, particularly on health sustainability. And I'll just give, some examples. Over the last 2 fiscal years, more than $164 million in Medicaid base rate increases have been approved across the healthcare system, across very diverse provider types, specifically to address sustainability. And then there have been some targeted investments in critical areas in the last 3 years that you all have had a hand in. And I'll just outline a couple of those. Provider tax relief for health agencies is one area where there's been investment. The mental health crisis system of care enhancements, so 988 mobile crisis alternatives to emergency departments. That's something we've all worked on together. Expansion of a youth mental health hospital that we expect to be in place in 2024 and 25, and residential services increases have been proposed as well. Designated mental health agencies have gotten some funding to plan for what the feds call certified community behavioral health clinics. My understanding is that we'll be calling those certified community-based integrated health clinics. But the idea is to really integrate mental health and other types of care. We've embedded mental health services in primary care. Some of the work that you've done on the blueprint expansion has achieved that. We're planning to expand high acuity skilled nursing beds. And then there's a proposal for updating the skilled nursing facility rate methodology. So that's just some examples of the really large body of work that's come out of this building in the last few years. And it's going to take that multifaceted approach to really solve our problems. But the AHEAD model, so what the AHEAD model does is it provides an opportunity to have Medicare join Vermont's healthcare reform efforts. They are already involved in our current all-payer model, and the AHEAD model would allow that to continue. And not only are they at the table, but it allows them to provide continued funding that they currently provide and additional funding as well to support our healthcare system to address some of those challenges. And some of that is outlined in section 11A of the most recent version of the bill. So specifically affordability, access to care, quality of care, health equity, and hospital sustainability are called out as goals that we think that the AHEAD model can address based on some of the design elements that we see. So in terms of section 11A, the Agency of Human Services supports the language as it's written for a number of reasons. First of all, I think you probably know that we're in the process of preparing an application for submission to keep the conversation going about the AHEAD model. That's due on March 18th. And so the language really signals support for exploring this federal opportunity. It outlines the goals that the AHEAD model has the potential to address. It makes it clear that if the model is determined to be beneficial relative to those goals, that the intent would be to support and include broad insurer and hospital participation. It outlines potential, it outlines some really important considerations for potential future agreement. So the language talks about Vermont's previous healthcare reform initiatives, the Blueprint for Health, the current model, SASH. Those are some examples of initiatives that we've undertaken here in Vermont. And there have been savings to Medicare from those initiatives. And so the language talks about making sure that they are considered in the next version of a model if we end up going forward. Vermont's status as a low-cost Medicare state is another really important thing that's called out in the language that we would want to make sure we considered if we were to move forward with this model. Cost pressures from the pandemic, from inflation, from workforce challenges, having some consideration of those as we move forward is important as well. And then the importance of the sustainability of our health system. So all of those are called out in the language, and we believe appropriately so. It also recognizes that it would be important to look at Vermont's regulatory structure if the state does end up moving forward with hospital global budgets. That is a significant change in how hospitals are financed. And so really, taking a look at how that would be regulated and so forth, makes a lot of sense. So I thought I'd also, I did hear the testimony the other day or the walkthrough of the bill. And so I thought I'd address a couple of questions that have come up. One question is whether the intent language would be binding, if we were to, participate in the ed model. The answer was that no, it's intent language. It would not be binding. But I did want to give the committee a sense of the timing that we're looking at with this model. So if we are selected, so we apply in March, CMS is signaling that they would select states. It's a competitive process, so there's no guarantee. They would select states in the May to June realm and notify them. And then if selected, those states would begin negotiating individually with CMS around July this year. So July of 2024 negotiations would start. A state agreement, because it's a state agreement between Vermont or another state and CMS, would need to be executed by July of 2025. So about a year from when the negotiations would start. And unless and until we can come to terms and an agreement is executed, Vermont or any other state would not be bound to participate in the model. So that's the timing. I just wanted to make sure you're aware of that. Boz testified on the other day, and they highlighted 3 areas of risk, and I just wanted to touch on those a bit. I mean, there's no question that the highest level of risk is for hospitals because it's a prospective, predictable payment that they would receive and have to live within. So that hospital global budget itself is the most significant risk for hospitals. They would get that fixed prospective payment. It would be based on historical revenue. There would be adjustments for inflation and other factors. The benefit is that it offers predictability and flexibility in how to deliver care, but it also does require hospitals to work within that set amount of funding. So that's the largest risk. Devin Green also talked about how the state, as part of that agreement, would be held accountable for what they call total cost of care. And that's basically your hospital, inpatient and outpatient services. And in the case of total cost of care, it would include what your Medicare Part B type services are as well. So your professional services, your office visits, and so forth. So the state, one of the accountabilities is that the state would be accountable for limiting the growth and that total cost of care. And she had noted that if the state doesn't meet its targets, that could impact hospital budgets as well. And I just wanted to read the language from the material that CMS has put out so that we're clear about what that risk is. So what it says is that CMS may, emphasis added, adjust Medicare fee-for-service hospital global budgets. So those individual hospital budgets, if the state does not meet established state Medicare fee-for-service costs for targets, following an opportunity for state remediation of the issue. So I just wanted to make sure you were clear. It's not a given, it's a may, it's a remediation process. The state doesn't meet those targets. And when they say Medicare fee for service, just to be really clear, this model, when they look at how it impacts Medicare, they're looking at traditional Medicare beneficiaries. They're not looking at Medicare Advantage beneficiaries that are in those commercial plans to provide Medicare coverage. So it's lingo, but that's what it means, is those traditional beneficiaries. So I would call this a potential risk for hospitals. So it might mean that they'd adjust, up, down, probably a little. But it's not a definite risk. And then third, she talked about the transformation funding that the AHEAD model is offering to hospitals that are early adopters. They're basically saying that if hospitals come in early for a couple of years, they would get a small percentage of their Medicare fee-for-service hospital revenue to use this is a huge change. So to use for transformation. The risk there is, hospitals are forced to stay in this model. It's a 9-year model. If a hospital decided to join early, get that transformation funded, but then decided at some point prior to the 6th performance year to leave the model, they would have to pay back that transformation funding. So that's a risk if they end up leaving the model early. So I just wanted to go into a little more detail on that position. They can talk about that. So I again want to emphasize those are the risks. Obviously we're looking at this model because we think there are some potential benefits. I already talked about the predictability in funding, flexibility in how care can be delivered, and Medicare funding, not only those transformation dollars, but some additional funding as well. The primary care component of this model really is about Medicare providing additional resources for primary care. They want to provide a per member per month payment for primary care practices that choose to participate. So that, there's that, there's, other opportunities, the Blueprint, SASH, and funding that the federal government currently provides as part of our current model. The only reason we get, it's about close to $10 million. Annually. The only reason we get that money is because we have our current model. They have indicated that they would continue that funding in Vermont if we were to continue with this model. So those are just some examples of the dollars that might come in, but also technical assistance and other supports from CMS. So I want to spend a minute talking about the language in section 8VA. It relates to roles in establishing and regulating hospital budgets. So there's some new language under the Green Mountain Care Board's powers and duties. And it says that the board shall develop a methodology for establishing hospital global budgets. I want to give you a sense of what that entails. We've had a technical advisory group that's been meeting, that's co-chaired by AHS and the Green Mountain Care Board. These are really detailed and important policy decisions that go into developing the methodology. So things like what kinds of adjustments do you make to a budget? Do you make adjustments for equity or care transformation or access? It could be on a myriad of topics, but they're really clear policy decisions. The things about, how the base budget is developed and what the trend is. All these decisions are going to be really, really important, and they're very policy focused. So we would argue that is, in the wheelhouse of healthcare reform. So, we would suggest that that language is going to be added, that it should be led by AHS in coordination with GMCB, and that we include people with, on the ground technical experience and other interests, like we've done in our technical advisory group that we brought together. So, you know, just want to, I mean, those are really important decisions. On the other hand, when you talk about, you know, implementation of that and regulation, that's squarely in the Green Mountain Care Board's wheelhouse. Some people here know that I had a stint as hospital budget review director at the Green Mountain Care Board, short-lived, but you know, I know the process of it. And that's clearly, you know, a critical duty of the Green Mountain Care Board, and it's codified in statute that way. So this is an example of how we can work together, you know, to achieve those common goals, both on the policy side and on the regulatory side. And sort of keeping some, you know, some lines there between design and regulation. You know, so, you know, but it shouldn't happen in a vacuum. That's the point. You know, again, for a year, we've been holding this technical advisory group. It's co-chaired by both us and the Green Mountain Care Board. And we've gotten really valuable input and recommendations on precisely this topic, estate design, hospital global budget methodology. So that's my comment on that. We really just believe that that type of coordination can and does work. Section 7. This is a carryover from the original version of the bill. And this is the section that relates to increasing primary care spending by insurers to at least 12% of the health plan or payers overall healthcare spending. You know, increasing primary care investment is a key goal and opportunity, really, and requirement of the AHEAD model, just like controlling growth and total cost of care. There's 3 state level accountabilities: that controlling the growth and cost, the level of primary care investments, like we literally would have to set targets and work to achieve that. And then the third is quality and equity. So for this particular language, I would, you know, I think we would recommend, it's a goal, we want to do it, but it's very specific in this section. And a lot of it's going to depend on how you measure. It seems like it should be really easy to measure primary care spend, and you know what, it's not. Like figuring out who actually is doing primary care, whether it's a setting that's primary care, what codes. You know, there are folks at the Green Mountain Care Board, because of the report that you all required, that you know, could go on for a while about the challenges there. So, you know, a lot of it's going to be how it's measured. So the specificity there is a challenge, but, you know, it's possible that some general language there, because it's a very important goal that would again signal our commitment to that objective, could be helpful. So that I'll leave it there, and I think folks might be working on recommendations there. There was also a question about whether the intent language in section 11A, going back to section 11A, should be included at this juncture. And I'll just note again that selection of states for the AHEAD model is a competitive process. And the application requirements, and believe me, I'm living, breathing, and sleeping those right now, but those requirements are focused really on whether states have the experience, the capacity, the policy levers, and the will to participate in healthcare reform that's this ambitious. And so I would again suggest that the language that you've put forth is supportive of that, really helps to signal that to the federal government, but it also gives all of us guidance as we work together and try to address some of those very formidable challenges and try to achieve those important goals together on behalf of Vermonters. So I'll leave it at that, and thank you for your time and the opportunity to be here. And
Well, thank you very much, Pat. And I think we may ask you to come back another time so we can have further discussion. And if you have your testimony, can send it, keep the extremely helpful.
absolutely
Really appreciate it. So
Yeah.
I think we'll just keep moving along, but your
Thank you.
comments on the specific sections of the bill are particularly helpful. So thank you.
Thank you.
We're just gonna bring ways ahead to see.
We're not doing questions.
We're not gonna do questions unless it's a question of clarification. Go ahead.
Okay, so as you've been talking, I've been scrolling through the requirements of the head model, and I have not seen anything that says that, a statement of legislative intent is required to apply. Maybe I'm missing something because it's a lot of information.
It's a lot.
But I think that you pointed to a number of things that we do that show our experience and commitment and our accomplishments, broadly speaking, that would put us in a good position to apply for the head model. But having this kind of forced, stilted, strange legislative intent, I actually think will be less helpful than more helpful. And I'm still not clear why anyone thinks we need it and how it could be helpful.
Yeah, you're correct, Senator, that there's not a requirement that there be intent language. I'll again say that sort of the focus on the, at the beginning, I talked about all the goals and that focus on particular goals that we think the AHEAD model can address, I think gives good guidance to us and to the variety of interested parties. And I think intent language signals, we've done things in the past that certainly suggest that that you're committed to healthcare reform here in the state. But this is really a signal about what would be coming in the future potentially if we were to be selected and participate. So I think it would be helpful. It's not a requirement, you're correct.
Thank you. All right, so we'll move on to Susan Barrett. Musical chairs.
Good morning. For the record, I'm Susan Barrett. I'm the Executive Director of the Green Mountain Care Board. Thanks for your time this morning. I wanted to share some feedback on yesterday's discussion, some information on the role of the board. And I wanted to say that Owen Foster, Chair Foster, is away this week with his family on school vacation. So please invite him back to talk more about these issues. I know he's eager to speak with you. Some of the materials discussed today, it was in last year's S-151, and then some of it is from S-211 that was added into S-151 in the version you saw yesterday. And you heard testimony on this earlier this session. So I want to start by making 4 points, and these are related to section 11A. I wanted to start there, and I have some comments on some other sections as well. But first, I wanted to start with the intent language. First, we only support the intent language to the extent it is meant to strengthen and improve Vermont's healthcare regulation and ability to control healthcare costs. And not remove and or weaken it. Couple of points here. Vermont's hospital system does not operate in a competitive environment. We all know we have monopolies here in the state by design. And our hospital costs have been rising dramatically. Vermonters are seeing double-digit rate increases year over year. And we're seeing our education costs also increase significantly, in large part due to healthcare costs and the premiums that they have to pay for their employees. We in the state of Vermont have severe challenges with affordability, access, sustainability of our hospitals, and quite frankly, almost all other providers in the state. A model like AHEAD will require a very robust regulatory structure to work. We cannot have access to critical services continue to decline in the state. Vermonters cannot afford to have commercial insurance rates continue to explode. They're moving higher much faster than national rates and far beyond what Vermonters' wages can justify. We can't continue to watch as our mental health, long-term care, and primary care erode right before our eyes. And we don't agree with the intent language. If there is some sort of assumption that GMCB regulatory structures should at this time or in the future be weakened and or removed. Second, AHEAD has a lot of attractive features. And the board is actively looking at that and trying to understand the strengths and the weaknesses, quite frankly, of the model. Because we want to know for our hospitals, for our providers that will administer this model, we want to know the risks, the strategies to mitigate those risks, and our healthcare system's preparedness to enter into this model. We encourage you all to ask similar questions the board is asking about the model and our readiness for it. Third, regarding the intent language and the participation for hospitals. We want to ask whether this is the right time to decide that. We heard yesterday and from Director Jones, we are just applying for the NOFO now. There's a lot of work to be done in terms of the term sheet of the model, and we won't know that until we sign an agreement. So those unknowns are that we don't know what the negotiations will say. We need to evaluate the model. The state has not yet assessed the risks to the model or of the model, and we haven't assessed the cost to administer this model and the benefit. So we really want to look at this as a whole and understand whether this is the right time to decide if mandatory participation should be adopted. I will say, in terms of other federal models and studies on this and federal evaluations, that voluntary participation in these models has not been as successful. The results have not been as successful. The current model we're in is voluntary. So I want to point that out. So whether we should do this or not, some hospitals should probably do it and should be mandated to do it. Or we decide to make it voluntary, if that's to be determined. Moreover, more work needs to be done to understand how many hospitals and payers need to be in this system to justify the cost. And it's not only the cost to to setting up the model, it's the regulatory structure. There will be a cost to that. If you're asking the board to regulate this model, we will set up a regulatory structure. We must set up a regulatory structure. So we need to understand that, and we really want to investigate this before we make any decisions. And we ask again that you do the same. And the last thing I want to say about the intent language is that the legislature, you all, some of you in the room now, dedicated significant sums of taxpayer money for the Green Mountain Care Board to evaluate hospital sustainability as part of Act 167. Nodding heads. 2 years ago that was. And we are in the middle of that process. It's a very robust process we are conducting. S-151's intent language should support not only potential ahead work, but also the legislature's efforts to ensure an affordable and sustainable hospital system as it's outlined in Act 167. There are important learnings from the work we're doing now in community engagement, and we'll want these learnings to be part of the decision to move into ahead of the readiness of the system. So we ask that you consider that, and I do have language that I will share. I'll give you an example of why this is important. So if a hospital's ability to manage to a global budget if that depends on where they can move patients into more appropriate settings of care, for instance, a long-term care setting, they don't need to be in the hospital anymore. And the goal, one of the goals of the global budget is to move those patients into those appropriate settings. We need to make sure that there are those settings available to them for them to succeed. This holds true for mental health beds, for step-down units, and for primary care. So we shared this language, which I'll read to you and I can share with you, Madam Chair. And we shared this with information to be added to this intent language, and I'll share it now with all of you. Upon the finalization of negotiations between the state of Vermont and CMMI over the agreement and a decision to participate by the administration and Green Mountain Care Board, it is the intent of the General Assembly to evaluate and implement any needed changes in Vermont law to ensure a transparent, accessible, affordable, and sustainable healthcare system that supports transformation recommendations from Act 167 of 2022 and strengthens the infrastructure of Vermont's mental health care, primary care, and long-term healthcare systems. We feel this work needs to be done in conjunction with preparation for ahead. Now I'm going to shift to some of the things you heard yesterday and to the details of S-151 version we heard yesterday.
Can I ask a question?
Yes, please.
So I'm looking at Pat Jones, and you did indicate that the ahead model has transformation dollars available. Would that be available for the current transformation or the work that will happen once transformation goes into effect?
So
That we're
there's-
doing in 167. I like this language. I like the language. So
there's
I'm trying to understand what dollars are available while we're right here.
Yeah, there's a couple of sources of funding. The one that I was talking about and that Devin spoke about yesterday is transformation funding, not a huge amount, but a small percentage that would go to hospitals for the work that they need to do. In addition, you may recall that that CMS is offering up to $12 million in cooperative agreement funding. for states to implement the model. And I want to be clear, that's $12 million over for the early adopter states over 5.5 years. It's not $12 million per year. So it's not a ton of funding, but it does provide some resources for states to help implement this model. So couple different sources there. I would call that transformation funding as well in a way, because it's really helping prepare states to implement this model.
Okay, thank you.
So I want to start in regard to the language and the testimony we heard yesterday. To take a minute to underscore the Green Mountain Care Board's role as a regulator as it relates to the AHEAD model and to global budgets. So we are a regulator with a system-wide view. We focus on access, affordability, quality, and sustainability of our healthcare system. And as it relates to today's discussion, one of our regulatory duties is establishing hospital budgets. We have Elena Barabee here, who's our Director of Health Systems Finance. She is right now working with hospital CFOs, meeting with them regularly to get their input on the draft guidance for FY25. We'll do that this spring. The board will have a very public process to approve that guidance at the end of next month. We're going to take public comment, we're going to hear from stakeholders, and then we will go through the hospital budget process over the summer and end in September with a decision for October 1st. When we finish with that budget process, we go right into planning for the next year, and Elena will be meeting with those CFOs again right after. I don't know if she knows this, but she does. She will.
I did last year.
Yeah, there we go. Again, this is a very public process, very open. All of our information is posted. I encourage you to look at it and to share with your constituents. In terms of the AHEAD model, Act 167 of 2022 actually planned for what we're doing right now. You all planned for a next all-payer model. And I want to share this chart with all of you. I can pass this out and we can share it. You want to just do kind of testimony? You can see on this chart the clarity of roles that you all accomplished 2 years ago in regard to the AHEAD model and other system level work. I need my picture. Probably know it from memory. We use this chart a lot, and AHS uses it a lot. It's a really great resource for folks. Thank you. Pass them along if you want. So if you look starting at the left, the subsequent all-payer model agreement, you'll see that AHS is in the lead with GMCD and collaboration. The next box to the right, developing value-based payment models and the hospital global budget development. I want to take some time right now to correct the record. You heard yesterday from the lobbyist from BOS that AHS is leading this work. We are working in very strong collaboration with AHS. But in the legislation and in terms of the contractor support and the direction, the Green Mountain Care Board is leading this work in collaboration with AHS. As Pat Jones mentioned, board member Robin Lunge and Pat Jones are co-directors of the technical advisory group that was created to inform this work. In terms of evolving our regulatory work, that's the next box. Act 167 also has direction, and I'm going to read a section of Act 167, which I think will address, is it section 8B about the global, the information that
Erase.
yes,
APA.
APA. So you already put this in Act 167 because we knew we were going to have to assess how we incorporate any new model and global budgets into the regulatory structure of the Green Mountain Care Board. Act 167 says it directs the board to determine how best to incorporate value-based payments, including global payments, to hospitals or accountable care organizations, or both, into the board's hospital budget review, accountable care organization certification and budget review, and other regulatory processes, including assessing the impacts of regulatory processes on the financial sustainability of Vermont hospitals and identifying potential opportunities to use regulatory processes to improve hospitals' financial health. So this is what we're doing right now. We're evolving, and Elena and her team are working on how we're going to work to create this methodology and incorporate it into our regulatory structure. We are open to an advisory group. We have several advisory groups at the Green Mountain Care Board. We're very open to them giving us recommendations. But at the end of the day, the Green Mountain Care Board will regulate this process.
So in the development stage, you're looking at support from the CAG, others.
Yes,
But then when things become firm, you are the regulator.
correct.
Boards.
And we'll,
It's clear. And I
From
think
the-
we heard that also from Pat Jones. So there's some consistency.
I didn't hear consistency in
Okay,
what
well,
Pat shared, so I just want to say that for
I
the
don't want to
record.
speak for Pat Jones.
Okay.
But I'm speaking.
And
for
we talked a
myself.
little bit about it before,
Yeah,
so,
no, I'm speaking for myself.
yes,
Developmentally, there's work going on and some advice that's given. Once it's set, it's the board, and the board is taking the lead in that regulatory decision making. Overall,
we would not want technical advisory group to set the global budget.
No.
We would want their
no,
input.
that's what I just said.
Yeah.
It's the board that's doing that. The board needs to maintain strength as a regulatory entity. That's what you're saying. And I think I agree with that. But I don't know what other people say.
So now I have a few sections to highlight in the current S-151. First, section 8, GMCD purpose. We'll get there. Section 8, section 8 in the current version. We oppose this change. We don't understand the goals of this change. We understand this was put into the draft by regulated entities. It doesn't make sense to limit GMCB system-wide view or define our purpose as a subset of our duties. Section 9. This was in section 12 of S-211. Section 9.
Sure.
We opposed this language in S-211, and we still do. This weakens GMCB's regulatory authority. It says GMCB can't make regulatory decisions without the agreement of the regulated entity. I'm gonna give you a quick example. Last year, the hospitals came to us and asked us to change the 2-year I don't want to use acronyms here, net patient revenue targets that we had established during the pandemic for them because we wanted predictability for them. They asked us to do that. We agreed to do that. During this process, we took their request, we brought it before the board, we opened it up for public comment. We had several discussions in public, as you all do. We received over 100 comments on this request. We ultimately decided to keep the original target. But we had a very open process along the way, and we will continue to do that as requests come in. So section 12B. This is studying regulatory timing. We also oppose this, and we opposed it when it was an S211. And we still do. As written, it's unnecessary, it's time consuming, and it's expensive to implement. GMCB has some already done 2 extensive white papers. I'm happy to share those with you after testimony on this very topic and researched this thoroughly. Stakeholders were part of that discussion, part of that research, most importantly. And then section 11A, again, the intent language. I just want to close by reiterating that we agree to this intent language only if it does not weaken the GMCB's regulation, diminish it, move it, or impact it negatively in any way. So that is all I have. I'm happy to answer questions. Thank you.
Oh, those are my thanks.
Yes.
It's like flowers.
Yes.
Okay. Wow, yes, secret button, stuff you see.
Are you finished?
I am finished.
Oh, okay, good. Thank you. So can we get your comments in writing? That helps.
And I'll send that chart too, and as a,
Yeah, oh, that'd be good.
The white papers.
and the white papers.
Yeah, links to those pages would be great.
And we'll also include the hospital sustainability page from our website, which talks about the work we're doing on community engagement. I'd love to have time to come back and talk about it. Maybe at
We're
the end
planning
of the
on doing
session.
that. I've talked with Chair Foster and
Perfect.
Representative Houghton about having
Great.
some reporting back.
Thank you so much.
All right, thank you. Jessup Barnard is here. I did want to ask one question. There's a section in the bill regarding appointments.
Oh, right.
And the nominating committee, and did you have any comments on that at all, given all the experiences that we've had with the nominating committee process and the board's interests in that?
I'd really like to defer to Chair Foster to come in and talk more about that, but I guess I would say I would like him to talk about it as well, but I will say from my experience as 10.5 years as executive director, the process has been murky at best, and it definitely needs clarification, so I would welcome that.
Okay, yeah, and obviously you're at the other end of what happens.
Right,
You're not at the end that some of us have been in,
that's right,
but some of your members have been involved in that murkiness.
exactly.
Thank you. So we'll move on to Jessup Barnard, who's up on Zoom. Thank you for being here, Jessa.
Good morning. Thank you for having me. Whoop, uh-oh. There we go. Can you hear and see me okay?
Yes, both.
Okay, perfect. Sorry, I am out of town and on hotel Wi-Fi, so we'll see how this goes. Appreciate you accommodating me remotely. Jessa Barnard, I'm the Executive Director of the Vermont Medical Society, representing individual physicians and PAs, and also submitting this testimony on behalf of the American Academy of Family Physicians and the Vermont chapter of the American Academy of Pediatrics. And we support a number of the sections of this bill. We see them as being very important for strengthening primary care and prevention services in the state. And I have submitted this in writing. I apologize in advance. My testimony is somewhat lengthy. I will try to summarize what I say live, but it's a big bill with a lot of sections that we care about, and we really wanted to give you the background and rationale for why we support the sections we do or have concerns with some of the other sections. So again, hopefully you'll have that as a resource all in writing. So I will be going in order of the sections of draft 2.1. I think I've caught up with the changes that were in the draft from yesterday. So section 1 talks about reporting the amount of premium dollars spent by payers on their own care coordination programs. We do support this additional transparency since the state supports care coordination centrally through a number of programs, including the Blueprint. We think it's important to gain an understanding of how payer efforts are either complementary or duplicative of other statewide efforts. So we support that section. Section 2 is regarding colorectal cancer screening. And what this section really does is remove an age to when payers would be required to cover no-cost screenings. We believe most payers are already doing this. I'm sure you will hear from some of them separately. So we think this is really almost more of a cleanup or consistency change rather than a change in practice. But best practices, so the United States Preventive Services Task Force, which sets as sort of the gold standard for setting screening recommendations, now supports colorectal cancer screening beginning at age 45. And I've included some statistics and justification for why that's the case and how, unfortunately, cases of colorectal cancer screening are actually increasing in younger adults ages 40 to 49. So how important this screening is. And so we think it's important to catch up with statute, and rather than referring to fixed ages, which is actually, this is one of the only screening requirements in statute that has an age accompanying it. We think that it would be more appropriate to refer to sort of national established clinical best practice guidelines, excuse me, like the USPSTF, rather than having an age fixed in statute that couldn't be as flexible to change as screening guidelines changes. This is somewhat similar to the ACA, the Affordable Care Act, which already requires coverage of preventive services. They sort of refer to the USPSTF rather than having fixed screenings or ages in statute. And then I'll just point the committee, there's a parallel bill. The House Healthcare Committee is considering H741, and Representative Kate McCann testified in support of that. So for some additional supportive material, I've linked to her testimony. Section 3 is actually removed in this latest draft, but just in not knowing which direction the committee will go, and we're comfortable with that, though I also wanted with its removal, but also wanted to say in concept, we were also supportive of commercial participation in statewide health reform efforts for the purpose that with the more consistency between payers in terms of design of payment reform programs, goals, quality measures, the more opportunity there is for reform to be successful, to have all parties moving in the same direction, be really clear for especially primary care practices, what they're supposed to be working towards, what measurements, what goals, and reduce administrative burden. So we do support the greatest participation by payers as possible. Sections 4 and 5 are on the minor consent for STI services. I know you've already heard a lot about this. I will not spend a lot more time on it other than to say all of our organizations strongly support this section of the bill. You've heard from Dr. Erica Gibson, who testified on behalf of several of our organizations. This section would move from just allowing consent to treatment after the fact of already contracting an STI to allowing minors to consent to STI prevention. And there are some very effective prevention measures that are available. So again, we would request the committee keep this section in the bill. We do not have a position on section 6, the risk-based capital report section. So I will move on to section 7. I do have some comments on this. This is the spending targets on primary care. We strongly support moving in this direction. And I have given some background supporting, as I'm sure you all already know, but some of the data around the more investment in primary care, we see better health outcomes, more health equity. Yet, and this is just a staggering statistic I want to highlight from the National Academies of Science, Engineering, and Medicine report on primary care. Currently across the country, primary care accounts for 35% of healthcare visits, but only receives 5% of healthcare expenditures. Vermont the DEVA and the GMCB did a 2020 report on where we are in Vermont, and I've included what the findings of that report. We're about 10.2% overall, so better than other reports. And again, as Pat Jones commented, it really depends how you measure primary care, and not all measurements are sort of apples to apples, but the way that this was a very robust process, a lot of stakeholder engagement in the development of this report and the methodology that was used. And so it included claims and non-claims-based payments. So Vermont is doing okay, but we still think can do much better. And notably, Medicare was one of the lowest payers. So we're interested in seeing Medicare's interest in a target for themselves in the AHEAD model. Not only does the state need to have a statewide primary care spend target, but they will be setting one for themselves. Interestingly, it does not look very high to us, but from what we understand so far, we'll be very interested to see how they propose increasing their own primary care investment, because as I think you're aware, over several years, Medicare has actually been decreasing its fee-for-service fee schedule that's impacted primary care. So we do not want to see Medicare accomplishing this simply through expecting increased utilization of primary care. We know we already don't have enough primary care providers, and it's very hard to get in. It's hard to get an appointment. We're really at capacity in our primary care system. So we will be watching very closely how Medicare proposes its own increased primary care investments. We would suggest, given that Vermont is at least applying for the AHEAD model and considering participation, we also agree with what Pat Jones said about moving to some more general language. And I've included proposed language in my testimony that we would like the Agency of Healthcare Services, really in collaboration with anyone interested, certainly the Green Mountain Care Board and primary care clinicians, would report back on the process for setting Vermont's all-payer primary care investment target. While we've done the report in 2020, it's likely that should be updated so we see where we are now and get some more kind of buy-in and engagement on how and what those targets should be for Vermont. And we would suggest that language says that in developing the proposal, the director take into consideration design requirements, basically for participating in AHEAD. But I will note we would prefer that this language not be specific to only if we participate in AHEAD. We think this work should be done regardless. We think a primary care target makes sense whether or not we move forward with AHEAD, but we certainly want it to be coordinated with that work. So that would be our suggestions. We have shared this language with AHS and with the Green Mountain Care Board. So I would encourage you to hear if they have any additional feedback on that specific proposal. Section 8 is the Green Mountain Care Board purpose language. We have concerns with the removal of the items of patient and professional experience of care, workforce issues, and administrative simplification. Not that the Green Mountain Care Board will necessarily always be the lead on those issues or only entity involved in looking at those concerns. But unless those are explicitly moved somewhere else, we think they need a home. We also think that the Green Mountain Care Board should certainly be looking at those as a factor in their regulatory decisions. For example, hospital budgets or rate review should be looking at professional satisfaction, workforce needs, and simplifying administrative burdens. So we would ask that rather than those simply be removed, if those want to be looked at, they be either given a new home or more clearly embedded in other Green Mountain Care Board regulatory work. Section 8 is the Green Mountain Care Board nominating process. We don't have an official organizational position on these sections, but I would say we agree that it would be helpful to have clarity in the timeline and process when a Green Mountain Care Board member seeks reappointment. We've also witnessed the kind of confusion or lack of clear process when that has come up in the past. Section 8A is a new section in this draft, taken from S211. So we shared similar testimony on this on 211. This is about a mandatory mediation process when a payer contract is terminated. We oppose, or at least have concerns about this section, about unintended consequences of requiring all providers, including smaller independent providers, having to go through a mediation process with the Green Mountain Care Board if there's a non-renewal of health insurance contract. There could be many reasons providers drop insurance participation, even from administrative burdens or slow payments to the practice closing or no longer offering certain services. We think this could be very administratively burdensome, and we are also unclear the criteria and capacity the Green Mountain Care Board would use to mediate such cases. We do not have a position on the new section 8B and 9, which deal with hospital budgets. I will move on to section 10, which is the workers' compensation rate schedule or fee schedule. We strongly support this section. Just for some background, the Department of Labor sets a separate fee schedule in rule for when an injured worker is receiving services through the workers' compensation program. So this rule so the fee schedule has not been updated since 2006. This has led to payments falling well behind current commercial rates and a real closure and lack of access to occupational health services for injured workers. We have heard further, even since we've started conversations with the Department of Labor about updating their fee schedule. Another hospital has eliminated entirely their occupational medicine program. Another has reduced clinical time. And then if somebody is going to just their general primary care or specialty care providers, many of them have been dropping coverage for workers or providing care under the workers' compensation program. The Department of Labor is well aware of this. They are working on updating their fee schedule. In fact, they have a RFP going out any day or week now to select a vendor to develop an updated fee schedule. But we still think it would be very helpful to have in statute that they are required to update their fee schedule at least every 2 years, just so that it does not fall this far behind. So that is what the bill asks for, and we support having that requirement in statute. Section 11 is around Medicaid primary care payment rates, and we strongly support sustained and adequate reimbursement for primary care services. The language in the bill currently is pulled from past statutory language, including language that was included in Act 167 of 2022. But there has been some updates since then. So we do think this language would need some modifications. For example, in the 2020 SFY 2024 budget just last year, the legislature, actually increased the primary care fee schedule to 110% of Medicare rates, which we very much thank you for and appreciate this work. It was extremely important for supporting primary care. And then there are also some methodological shortcomings of benchmarking to Medicare, because that fee schedule does not include inflation. And as I mentioned previously, Medicare has been cutting their fee schedule. So even though you required this increase, if we are still doing that as a percent of Medicare, that could lead to decreases over time. So to address those problems, there are kind of several approaches. One is to benchmarking the fee schedule to a specific Medicare year, as you propose in S151. We, however, would ask that that be set at 2021 rather than 2022, which is in the language, because there were actually cuts in 2022. The other is to require the fee schedule to incorporate a medical inflation factor. So the bill language currently refers to the Consumer Price Index. We actually think that would more appropriately refer to the Medicare Economic Index. That's kind of a measurement specifically of healthcare inflation. And then a third piece, which actually the House Healthcare Committee has recommended go in their budget language, is asking DVHA to look at potential methodologies that actually separate what's called the conversion factor, the number used to translate the Medicare fee schedule into a dollar amount, from Medicare's conversion factor. So it would basically be, not to go too into the weeds, but be keeping Medicare's formula for paying, but have a separate kind of dollar conversion factor. So that work, we would ask when the budget comes over to you, we would encourage you to take a look at that, and we support kind of both approaches and the language in the budget, as well as what you are proposing in 151. We are comfortable there's sort of a lead-in clause in this language about meeting 100% of Medicare rates for all provider types, but then it says with first priority to primary care providers. While we are primary care and that is a top priority for us, we are comfortable removing that clause because we actually support sort of a long-term goal of all provider types being at 100% of their Medicare fee schedules, as well as specialty physician services. So I don't think that necessarily impacts the actual substance of this section, but just sort of as a legislative intent statement. And our intent is that we actually think all providers should be as close as possible to 100% of their Medicare rates. Okay, sorry. Again, apologize for the length of this, but these are important. There's so much in this bill. Want to highlight our feedback, and moving on to 11A, which is the new AHEAD model legislative intent section. We appreciate the benefits of documenting legislative intent regarding participation in the AHEAD model. Our feedback in looking at this section, and we only sort of saw it yesterday, is that it is fairly hospital centered. And we also think there should be intent around primary care participation because there is a whole component of the model focused on primary care. And we want to thank the Agency of Human Services for all their partnership on educating primary care about what the model would mean and require, and hearing our feedback. So we really feel like there's been a lot of engagement with AHS and primary care. There's been a primary care work group, and we linked to the materials from the website where they are posted. They've been very helpful. And a presentation from December 15th, I think, would be particularly informative because it crosswalks what Medicare is proposing, adding to funding for primary care, a $17 per member per month, with existing primary care programs in Vermont, the Blueprint and ACO payments. So sort of how that stacks up against each other. And at first glance, $17 per member per month of new funding coming into the state sounds very attractive and a great way to support primary care. But we do have some concerns with the specifics of how this would impact primary care. First, I want to highlight this is only linked to the fee-for-service Medicare patients of a practice. So as Medicare Advantage grows, that would shrink. And also pediatric practices in particular, who see very little Medicare, would perhaps potentially lose all of their ACO payments if an ACO goes away, but basically have very little gain if they only have a handful of Medicare patients. So we're very concerned about the impacts on pediatrics. And then we're also concerned about the impacts on independent practices currently participating in OneCare's comprehensive primary care program, which pays a capitated payment to primary care and also above a 105% of fee-for-service for a certain category of services. So this is providing sort of steady, predictable income to primary care practices. And our latest understanding is that CMMI has held fairly firm to not introducing a capitated payment model sooner than 2027. So there could be a gap of several years where this goes away and there is nothing really there to replace it. And another concern is on administrative burden. I'll try to avoid getting into the details too much on this, but want to just explain it that Vermont's all-payer model currently qualifies as what's called an advanced payment model under CMS's merit-based incentive payment system. This is kind of CMS's pay-for-performance model for all physician practices around the country. But if you are participating in an advanced payment model, you don't need to participate in MIPS. If the AHEAD model does not count as an advanced payment model, which is our current understanding of CMMI's position, though we know AHS is well aware of this concern and has been in a lot of conversations with CMMI about it, so this could change. But our current understanding is that it would not qualify and that practices would all of a sudden need to jump into a whole new measurement and reporting system. By one estimate from the AMA, compliance with MIPS costs over $12,000 per year per physician and 53 hours of administrative tasks to comply. So regardless of the potential strengths of the model, and I don't want to say there aren't attractive elements of it, this will be a change and disruptive for primary care practices, especially if it comes with the ending of a statewide ACO, leading each practice to need to assess the financial impacts of participation. Will it help them or hurt them? Adopt new administrative requirements, such as entering direct contracts with CMMI and individual payers rather than an ACO helping with that process, and change quality and data collection methods and targets. So due to all of those concerns, we have some suggested language for addition that really calls out, again, if this language moves forward, which lays out the intent for sort of some guardrails for participation and what we would want to see in the model. We would want to see that that before we enter it, that we know and we have plans for how the model would actually hold harmless or increase investments in all types of primary care practices, including independent and pediatric practices, and that it would not greatly increase administrative burden by, for example, subjecting all practices to the MIPS program, and supports practices in making this transition. So that language is in my testimony. Getting there. Section 12, looking at healthcare contracts and fee schedule. We would want some more information about this. We have some concerns about sort of what this would mean for practices and what it would accomplish. There have also been many of different studies in the past couple of years examining reimbursement rates and equitable payments. And we think it might be more, again, depending what the committee is trying to accomplish with this language, more productive to look back at what we've already studied and look at next steps rather than kind of some general language about examining specific contracts and equitable payment. This is my last comment is actually a section that is no longer in the bill, but I wanted to highlight it. So there was an original section of 151, section 2 is introduced, that asked for a study of the blueprint per member per month payments to patient-centered medical homes. Your committee recommended taking this section out because that report was already asked for and done. So I agree we don't need the current language. However, we would encourage the committee, if moving forward with this bill, to actually look at the report that has now been done and the recommendations to increase and get some more fair payments by commercial payers to support patient-centered medical homes. So currently Medicaid has the highest payment to this program compared to commercial payers, and also only some commercial payers are participating. But the report gives some suggestions for how to increase commercial payments to equal Medicaid payments, and also thinks there are some mechanisms for additional private commercial payer types to make these contributions to the Blueprint program. This is to support primary care practices that meet patient-centered medical home qualifications. That's a fairly extensive sort of approval process and administratively burdensome for practices. So we agree with the report that the rates they highlight would more accurately support maintaining patient-centered medical home recognition. So thank you. Those are our comments. I'm happy to come back in the future to talk about any of the language suggestions, and really appreciate your committee's look at this bill. We do think there are a number, as I said, of very important components that support primary care and prevention services. Thank you.
Thank you very much. And thanks for taking time when you're away. We really appreciate it. The testimony that we have posted differs somewhat from the testimony that you have just provided, including the language. So if, as we go.
Oh, okay. I apologize. Maybe it was before I updated it for the latest draft of the bill. Let me look at that, and I have it on my computer, so I'll make sure I
It
get that.
looks like that's the case, but just send it along to Kiki and we'll get it.
Absolutely. Thank you for letting me know.
Yes, so thank you very much.
Thank
We'll
you.
let you go, and time is fleeting, unfortunately. So we will have further discussions on this. So Susan Risdon is here, and thank you for being here. So what I'm going to ask is that, as we have 3 more people to testify, and we want to get to everyone, if you have some concurrence with some of the comments, fine. And I think you have your testimony. Do we have your testimony?
I actually submitted it, but there was an error. So
Not there. Well, it will be there. That would be great. Thank you. Thanks. Introduce yourself on the record, and we'll continue.
So, hi, thank you for the opportunity. My name is Susan Ridson. I'm the Executive Director of Health First. We're an independent practice association that represents 62 specialty care and primary care physician-owned practices across Vermont. And lucky for me, we align almost exactly with VMS's comments. So I'll really just basically point out the areas where we might differ a little. So I'll just work through the bills. Section 2, we agree with everything that VMS says. As well as section 4 and 5 on this, sexually transmitted infections. Section 7 dealing with, dollars for primary care, we strongly support increasing that. Thinking that, there should be some consideration of alignment with the AHEAD model. Just to make sure, not to say that we will go ahead with AHEAD, but just making sure that we're not in contrast to that. And one of the things I see on, line 6 of page 6, it talks about, increasing the primary care spend fee for service portion. Depending on how, CMS counts primary care spending, that may be necessary, just something to keep in mind. Like, want to keep our options open there. Section 8, we did not understand the intent of removing items 3, 4, and 5, from the Green Mountain Care Board, list of duties. We're neutral on the nominating and appointment process changes, but, support increased clarity and transparency around that process. Like VMS, we have concerns about the language requiring, Green Mountain Care Board mediation prior to termination of contracts. Sometimes that's the only, avenue, practices have, so just have some caution there. We thought in section 8B made sense to include the global budget methodology to the Green Mountain Care Board list of duties. We strongly support the increases to the workers' comp, fee schedule for all the reasons that Jessa mentioned. We also strongly support the intent to ensure Medicaid reimbursement, is adequate. Thank the committee for, the award last year on that. Jessa beautifully pointed out all the concerns with aligning to Medicare. We have those needs concerns. And recommend that it be benchmarked to the 2021 floor, or Medicare, or if we are.
21, right?
Yes. So section 11A, we question whether this language is necessary, considering the state may or may not participate in AHEAD. However, if this section does remain, we thought it was pretty hospital focused, and whatever happens when the all payer model ends, whether or not we do AHEAD or something else, the disruption to primary care is going to be significant. So we agreed with Justice proposed language if the section is going to stay in, that it takes into consideration holding primary care harmless. We do have big concerns with the pediatric practices under the AHEAD model, or just when the all payer model ends, as well as just our independent practices, particularly those in the CPR program. So really want to pay some attention to making sure that the disruption to those practices is really minimized, and that their income streams remain stable. It's very important for our practice.
Especially during the gap years.
Right.
Yeah.
Yeah. And that section 11 is all, in conjunction with AHEAD. But I feel like some of the things that were pointed out, that we need to be looked at regardless if we do AHEAD or not. It's the ending of the all payer models, so we really need to ask those questions. And section 12, we're unsure about the intent of having the Green Mountain Care Board review contracts. Just as Jessa was, we wonder what the goal is. Would the practices be able to share their grievances with the board on their contracts? We're open to the possibility, but we wanted to kind of learn more about that. And we strongly support the language pertaining to reimbursement equity, as you might not be surprised on that. But we're deeply disappointed that we're still at the state of talking about it. Because there's been numerous bills and reports, as Jessa pointed out. We've had Act 54, Act 143, Act 85, and these numerous reports. I would like us to move from talking about it to actually solving the problem. We're happy to dig in and work with folks on this. The ramifications of this unlevel playing field is significant, not just for independent practices, but for the system at large. 30 years ago, there were 4 out of 5 physicians were independently practicing. Now we have 1 out of 4. And that, basically has led to a more hospital-centric consolidated system, which by nature is just more expensive. So fixing this issue would benefit the entire system. So that's our thoughts on that. Happy to take any questions.
Thank you for that. As you said, the more affiliations happen, the costs increase. We've heard that.
And then we also have the issue with consolidation with what happened with Change Healthcare. When you have this huge system running everything, it can be taken down in one fell swoop. But if
Don't
we
want
have,
that.
no, but if we have independent doctors where you get really personalized care, we think that's a good thing for sure.
Thank you.
Yeah.
Thanks for being here, and thanks for testifying the way you did. That was very helpful. And we do have it for posting. We do have your testimony.
You will.
Yeah, good. All right,
Yes.
that's great. That's very helpful. All right, so we have Sarah Teachout from Blue Cross and Blue Shield. Thanks for being here. Thank you much, Senator Gulick, for keeping the blood sugar level.
Think you need it.
I think we do.
No crashes allowed.
Sarah Teachout, Director of Government Relations for Blue Cross and Blue Shield of Vermont. I was gonna step through the different sections of the bill because I actually haven't ever done that here in this committee, so. Section 1, which adds to the total premium revenue, report, specific reporting on care coordination, done by health insurers. So if you read it, this is what happens when we file our rate review filings with the Green Mountain Care Board. We have a 1-page, it's called the plain language summary, because our filing is essentially a giant binder of material. And so for the public, I guess, we kind of summarize. So this would have us specifically add how much we spend on care coordination programs. And while we believe it's a very important service for our members, and supports cost containment efforts within the organization, among other objectives, I think being required to itemize this one expense among everything that we spend for our members and premiums stands out as really particularly unusual. So we oppose this. Section 2 on the colorectal cancer screening, Blue Cross already covers in the way that it's being designed here, and so we have no opposition to changing the language. Our members already receive screenings where appropriate, following national standards and guidelines. Section 3, which you have removed, mandating insurer participation, has appeared in several bills this year. And I've already spoken about it, but I need to be clear that we either have a model where everyone is in or everyone is voluntary. We can't just require parents to participate. It won't work that way. And I hear a lot, in talk that Blue Cross and Blue Shield of Vermont pulled out of the all-payer model, and that's why this language is necessary. I'd like to remind everyone that we participated every year for 10 years. We were the first payer in. We helped design all the financial pieces of that model, and we only pulled out. It was very clear that it was not improving anything for our members. So I think this is unnecessary, but when we get to talking about this, we need to talk about it globally and not just for insurance. Section 6 is the risk-based capital report as part of Act 152 reporting. So Blue Cross and Blue Shield of Vermont already provides vast quantities of financial reporting to DFR. And the only thing I'll say here, this is a public report, so there would be a number, RBC percentage, that I don't believe probably most people in the public would understand. And I'm not sure what the intent is of having us do this. I will also say that historically, we have been prohibited from publicly promoting that number. It's our solvency number. It's And I guess I'd love DFR to be here because it's not a secret per se, but it's not a number that we've been ever allowed to talk about super publicly. Other insurers in other states do. For example, the Blue Cross and Blue Shield of Michigan is having a press conference on the 1st about their financial situation. So it's different in different states, but my understanding is there's a statute that has prohibited us from talking about it in the past. You know, it's a number that can be accessed if you know how to get to it at the DFR website. And I think it would require some education for people to understand what it means. DFR has a risk-based capital order for Blue Cross and Blue Shield of Vermont. It sets a range for our solvency. And it's from 590% to 745% RBC calculation. And so understanding where we fall within that range probably would be important. So then the next section, primary care spending allocations. I participated in the study, it seems like a long time ago now, where we figured out the percentage, you know, we defined primary care, we worked pretty hard on it. And Blue Cross and Blue Shield of Vermont recognizes the critical importance of primary care in our healthcare system. And we do our best to support primary care providers, but in the current environment, basing a calculation on the percentage of the total spending without negatively, and I appreciate the pieces in there that say without negatively impacting premiums, increasing fee-for-service payments, or increasing overall health insurance expenditures seems impossible to accomplish, especially because the amount that goes to primary care is measured as a percentage of the totals. And the recent enormous price increases for hospitals and the giant increases for pharmaceuticals make it impossible for, it's a target we can't achieve because those sectors of the healthcare space are growing so much faster than everything else. So then on 8A, the mediation prior to termination of contracts, like the Medical Society and Health First, there is a lot that goes on in healthcare contracts between providers and payers, and they're terminated for a whole host of reasons. This could create a huge amount of unnecessary work for the Green Mountain Care Board when I think your goals are different. And so at the very least, you would want to have them only reviewing contracts that impacted, you know, thousands of Vermonters. We already report, so you know, to DFR if a contract non-renewal will impact network adequacy, because we're required to have, you know, coverage for all of our members. So that's already in statute. So this is kind of a problematic new section. Section 8B, the Green Mountain Care Board developing the methodology for establishing goal hospital budgets. We 100% support this, but I would note that there is misalignment between the policies that you're putting here in this bill and what's happening in the budget. So the Agency of Human Services is receiving millions of dollars to work on global hospital budgets, and to my knowledge, the Green Mountain Care Board is not. So having worked on financial policy for a huge portion of my career, I know, and I think you all do too, that where the money goes is extremely important. And without the financial resources to do their work, the Green Mountain Care Board, you can tell them to do all kinds of things, but you're undermining their ability to do the work they need. So while I support it, they need the funds to do that as well. And then Section 9E on the benchmarks, also the Green Mountain Care Board, we oppose this section. We don't know why the process for establishing benchmarks should be different than any other element of global hospital or hospital budgets. So there's guidance, there's the process that Susan Barrett talked about. This one piece would be without is unusual and unnecessary. So then we get into the intent language, and I wanted to speak about Blue Cross's vision for either healthcare reform or the model, whichever the state chooses to move forward with. So we believe that many of our members and customers believe that if all Vermonter approach with government providers and payers collaborating on a shared set of goals must be the basis for the future of our healthcare system. We can support a head model that focuses on improved health and clinical outcomes for all Vermonters, identifies payment reform not as a goal, but as a tool to enable delivery system reform, acknowledges that affordability in all segments of the population, including commercially insured Vermonters, is a critical success factor. And I see in there that there's a lot of emphasis on our low Medicare rates. We have some of the highest commercial rates in the country. So that really needs to be looked at here. We believe it needs to be sustainable from multiple perspectives for all providers, including primary care, mental health, and hospitals. It needs to be sustainable for all payer populations, government-funded care programs, and individuals and employers who pay premiums and out-of-pocket costs for commercial health plans. And it needs to be sustainable for Vermont taxpayers who fund our healthcare system through inherited ones. We need to insist upon consistent, simple, and measurable models to ensure that regulators, legislators, and the public, the citizens of our state, all have transparent access to the critical information about the quality improvements, the cost impacts, and the efficacy of the reform programs. We need a model or a healthcare reform system that is dynamic and designed to evolve or even pivot when it's not achieving the desired outcomes and that regular Vermonters are not better for the reform efforts. This is that new AHEAD model is a 10-year model. The last one was 5 years. If we see that this isn't working for Vermont, we need to change it and have the ability to improve it. And that's important. And finally, we believe it needs to be regulated by an independent body free from undue. So if together as a state we can satisfy these conditions, then we believe we should move forward. So the last section, the rate setting pieces that you were speaking about, we have the same questions, I think, as the Medical Society and Health First. There have been a lot of discussions about equity among payers and providers is something we struggle with, but I would know that I think the struggle is often in comparing themselves with hospitals. The hospital rates are set through a different process and they've been escalating dramatically. And so it's virtually impossible to balance what's happening there with what's happening in the rest of the health system. So we do support equitable reimbursements, but it needs to be also practical. We can't increase everything across the system at rates of 50 to 20% a year. That is my.
I think there's a lot of agreement about that.
Yeah, I'm not saying anything, nobody here doesn't agree. So thank you.
Oh, thank you very much. And we don't have it yet, but.
I know, I was
I know,
doing it
you've
last
done
night, so.
coordinated, so that's good.
Thank you so much.
Thank you, Sarah. And Mike,
Good morning still.
good morning.
Mike Bishop, healthcare advocate. So my plan for right now is to speak for a moment. I'm going to start with the intent language and then go through sections of the bill. And then I have some suggested language for you about the HCA.
And we don't have your comments.
So you don't have it.
Yeah.
And I'm a little bit old fashioned today, I'm on paper. So let me first say, I don't know if we need intent language. I've heard the discussion. Intent language is a familiar tool for the legislature to speak clearly about something. And so I enter into this section with a recognition. I don't know if we need it. I'm not going to argue for or against it, but if we have it, it ought to be right. At least from each and every one of our perspectives, of course. So the chair made a valiant effort at pulling together all the parties and looking for consensus. It came a long way. Didn't completely land on consensus, as I think you've heard in testimony today. So at least from the healthcare advocates' perspective, it comes close, but I want to suggest, one little bit. Well, let's just change. Ways. Like others, I will echo, I am supportive of moving forward in this stage of the head. I think we have to see what negotiation with the federal government looks like. But if the outcome of moving forward with a head,
I need one more for PP.
sorry. If the outcome of moving forward with the head is any kind of diminishment of the board's authority to do hospital budgets, the HCA is very concerned. HCA will not be supported. The intent language that was before you is the first top, and then at the bottom, I'm suggesting an alternative to the last paragraph. And I'm just gonna read it. I think it's clear. It's the intent of the General Assembly that if the administration and the Green Mountain Care Board and Federal Centers for Medicare and Medicaid Innovation come to an agreement on the HEAD model, and the state approves that agreement, the Green Mountain Care Board shall convene interested stakeholders to consider how to appropriately regulate hospital budgets in the context of the HEAD global budgets. If the board determines that the statutory changes are needed, the board shall propose these changes to the General Assembly in a timely manner. And I think what I'm trying to say here is, and others have said clearly before me, it's the board's job to do hospital budgets. It's a really interesting question, how to appropriately do global budgets and hospital budgets overlapping. It's an impossible question to answer until we know what the heck global budgets really are, the real terms. But it is an interesting question nonetheless. And once we have the real terms of it, once we know the scale of it for different hospitals, it's a good question to task the board with. I think it's the board's job. It's my main point here. I think the language that's in the bill that says the administration and the board in its negotiation with IQ, I'm not going to go back to language, it's a little confusing to me, and I think it sets us up for lack of clarity or conflict with it. I guess I'm hopeful that the legislature says clearly in this intent language, we are clear in statute, we were clear in Act 167. Thank you, Green Mountain Care Board, for repeating some of that language. It was useful for me to be reminded. We have said it before, that it's the board's job to do this. Is there any, I'll keep moving, but yeah. So about the bill itself, I'm going to go quickly through the sections and recognize where I agree with people. As one, in section 1, as one of the handful of people in this room, actually in this room, there's more people than in most rooms, who look forward to the plain language summary of insurance rate filings. I agree with Blue Cross's comment here. That it seems strange to pull out one individual section. And I also want to recognize the board has been doing some work on this very question: how much primary care dollars in insurance payments claims are going, how many dollars are going towards primary care? So I guess I would split the board's work on that. No comment, agree with section 2 on colorectal cancer, agree with the decision to pull section 3 out. Agree with the committee's work on consent to preventative services for minors sections. I have to sort of restrain myself to not vent about the inability to talk about RBC, so I will restrain myself on that. Very available, and it seems strange to us that we can't talk about it publicly. But I don't see the reason for that section. I'm gonna go we skip to section 8. I agree with what others have said. I think today VMS said it the most in line with my view, and I am confused by the purposes of section 8, starting on the bottom of page 6. I don't know why we wouldn't want the Green Mountain Care Board then doing all of its proceedings to be looking at enhancing patient care and workforce and reducing administrative and improving administrative simplification. So I would oppose section 8. I'm supportive of the effort on the nominating process sections of the bill. I am similarly confused as others about the section 8A, the mediation. I think I know where it comes from, but I think it's more complicated than it might have seemed originally, and would have concerns about it. I am supportive of 8B. I think it makes sense to be clear in statute that this is the board's job. And I'm gonna echo Blue Cross's statements that they made a second ago, that the board has to be appropriately resourced to do the work. So section 9, we don't have any problem with D1 at the bottom of page 11, but I have substantial problems with E1 at the top of page 12, and I'll spend just a moment on it. I have real concerns that will undermine the effectiveness and the accuracy of the board's efforts to the hospital budgets. And I've got to give an example. It's in a different regulatory process, but it's current. This year, in the board's decision about the ACO, the board said, hey, we need you to affirm that the money you say is going towards primary care is really going towards primary care. Now, the ACO, OneCare, appealed that and said, board, you're overstepping the bounds. You can't reach into our budget on that level. And that appeal is before the Green Mountain Care Board right now. I am very afraid that this language will further limit the board's ability to do things like track primary care spending and making sure it's going to the right place. For the life of me, I don't understand why OneCare appealed the board's request that they affirm that the money they say is going towards primary care is really going towards primary care. It may be, we can draw our own conclusions about why they have appealed that. But I will say there's at least a possibility that they want to knock back the board's authority to do this kind of looking at the details of budgets. So again, that is in the ACO world, but it's so close to the mark in this language. I wanted to bring it to your attention if you were aware.
When did the appeal start?
I would have to update a few of the details. It's current.
Susan?
I'll follow up. I want to give you
Yeah,
the,
that was ridiculous. I think
I'll
it's
get, I'll
been
send
before
information
that.
on where it's at.
So Michael, I'm not gonna rush you, but
But you already
you
mentioned.
get to some,
But
you get there, it'd be great.
Um,
Because we can read some of the backup information that you'll provide for us.
so I've already commented on section 11, and I'm gonna echo others' concerns about the study. And if you'll allow me to spend a moment on second thing on the agenda. So this is new language for you. And this is the proposal that we are making about our own statutes. And let me just speak plainly about it first. In hospital budget process, the HCA, the healthcare advocate, gets to ask questions of the hospitals. In the insurance rate review process, the healthcare advocate gets to suggest questions of the board's actuaries. And there has been a practice over all of the years. So this is in 3A, this change here that I'm talking about. there's been a practice of not allowing us to ask the questions that we want to ask. And I have a specific example. I apologize if I'm going to go over my time here, but I have a specific example. This year, the two carriers approached us very differently. Blue Cross said, hey, if you ask this question a little bit differently, we'll be able to answer it more accurately. They negotiated with us, we came to agreement, and we submitted our question. There's no problem. The other carrier said, no, we objected. Everyone, many of our questions. And we had one question about, it was about $40 million that we couldn't find in, we couldn't track where it went in their reserve. I don't mean to imply that there's anything wrong here. We couldn't ask the question to find out if there was. We go down a lot of false leads, find out that there's reasonable answers. But we hired a contractor to help us understand what was going on in their financial statements. The contractor couldn't figure it out. And so we asked a question about something, an entity that had been created and had disappeared, and we couldn't track where a pile of money was. Board didn't allow us to ask the question in pre-hearing questions. So we came to the hearing and asked the question, and surprise, surprise, it's a complicated question that the carrier wasn't able to answer it fully in the hearing. And to this day, I don't. And so we think if you're gonna ask the HCA to go into the ring of insurance rate review, and on behalf of Vermonters, you can't tie the hands kind of back. Pre-hearing questions where we develop our case. And so it's super important, something that's been a problem for us for years, and finally feeling motivated to go ahead and propose that change. There's a whole nother section in here of underlined language that is pulling from the board's rule on posting documents and putting it into the statute because we feel it's super important. We all do a lot of work that the work we do, that the record is complete. When we file a motion, when documents are exchanged, all those documents go up into the full record. So.
And so we could get that electronically.
Absolutely.
Yeah, along with your testimony, that would be helpful. Thank you.
Thank you.
For taking the time to go through everything. So we're gonna go off live for 5 minutes, and then we'll come back to S263. There's a lot here to get